So welcome to today's panel. We administered Narcan, now what? Reducing future overdoses and improving public safety. My name is Karen Moline, and I'm a project manager at IACP for the Safety and Justice Challenge, an initiative funded by the John D. and Catherine T. MacArthur Foundation to reduce over-incarceration and rethink the way America thinks about and uses jails. Because of the limited time we have today, I'm going to briefly introduce today's panelists and then let them get right to their presentations. I'm going to do it really fast. Our first speaker, Jack Charlier, is going to explain the Naloxone Plus framework and how connecting drug-addicted individuals to treatment post-overdose can reduce the cycle of addiction and justice involvement. Jack is the National Director for Justice Initiatives for the Center for Health and Justice at TASC. He recently developed the opioid OD prevention strategy for reentry training for the Center for Substance Abuse at SAMHSA, is a nationally recognized expert in pre-arrest police diversion, and is co-founder of the Police Treatment and Community, or PTAC Collaborative, which he's going to talk about during his presentation. Chief Eric J. Gunther is the Public Safety Director for the Village of Mundelein, Illinois, and has been the Mundelein Police Department with the Mundelein Police Department since September 1995. He has served as Deputy Chief, Commander, Sergeant, Criminal Investigator, and Patrol Officer. He has a bachelor's degree in Criminal Justice Law from University of Wisconsin-Platteville, and a master's degree in Public Safety Administration from University of St. Thomas. Chief Gunther is going to discuss A Way Out, a county-wide program launched in 2016 to fast-track users to treatment. And John Tharp was sworn in as the 45th Sheriff of Lucas County, Ohio in January of 2013. Before joining the Sheriff's Office in 1997 as the Director of Court Services, he had a 25-year career with the Toledo Police Division, where he was assigned to field operations, the Narcotics Squad, Drug Task Force, and Homicide Squad. In July of 2014, Sheriff Tharp launched an addiction resource unit, the first of its kind in the nation, to work with heroin overdose victims and their families. This unit, now called the Drug Abuse Response Team, or DART, has been designated by the Ohio Attorney General Mike DeWine as a statewide model and pilot program, and that's what we're going to hear about today. Gentlemen, thank you for coming today to talk about your programs. Let's start by learning about Naloxone Plus.
All right, good afternoon. How's everybody doing? Cool, good. My name is Jack Charlier, as Karen said, and since we won't have a lot of time for Q&A, I'm just going to cut right to the chase on this. First, I want to thank Karen from IACP, and then the other panelists, Chief Gunther and Sheriff Tharp. You've got a great group up here of people who have real deep experience in offering solutions. And the theme for this IACP conference is Solutions for a Safer Society. And so I want to begin by saying what we're going to present to you is part of the solution to America's opioid crisis that is occurring in many communities across our country. So by a show of hands, how many of you feel that for your community or know for your community that opiate use, opiate overdose, and opioid death is already a problem? Okay, not surprising. For those of you who are here that that's not the case, in other words, you want to come and learn something new, raise your hands. Let's see if we've got... Okay, so for the panelists, for all of us, you're all involved in this already. The solution, and I'm going to just do this and we'll get into the presentation, the solution really is about, as you heard Karen say, connection to treatment. And we'll talk about why that is. How many of you, for those, well, everybody raised their hand. Since everybody raised their hand, how many of you have something where your officers, one, are carrying naloxone? Let's see a show of hands. I think that's just about everybody. And then how many of you have something after naloxone to connect folks to treatment so that your officers don't have to do the repeat naloxone over and over? So keep those hands up. I want to see. Okay, good. Excellent. So thank you for all of you who are doing that. And for those who are here whose officers are carrying naloxone and now you're ready for the next step, you are absolutely in the right presentation. If you're already doing it, you're in the right presentation too, to hear some of the things based on science and research that will increase the connectivity to treatment, reduction in overdose, and then reduction in overdose death. So thank you for being part of this. And again, coming back to IACP's theme for the conference, Solutions for a Safer Society. This, in fact, presentation is entirely designed for that. All right, let's get going here. Already talked about that. We'll explain what the Naloxone pre-arrest diversion framework is. And so I'm going to do a general overview of what this looks like. Depending on where you go in the country, you're going to see elements of what I'm going to present, and then Chief Gunther and Sheriff Tharp, as Karen said, will give you the actual efforts that they are doing on ground that are built up quite a bit, right? These are not new efforts that just started a few months ago. They're built up quite a bit. Okay. The idea behind what we call Naloxone Plus, and I'll explain what the plus means, is that you're saving lives twice. So when I asked you how many of your officers carried naloxone, Narcan, every hand went up. That's saving a life once. But based on the science and research that we've known for 40 years about drug treatment and how people get into recovery and stop using drugs and then stop committing crimes related to drug and drug activity, you have to save a life a second time. The first time is the administration of Narcan, naloxone. I'm not here to do a product placement for Narcan. The first time is the administration of naloxone. The second time is the connection to treatment and into recovery. And that's what Naloxone Plus refers to. The plus is that second life-saving effort that you, as first responders across our country, are being involved in more and more and more. Before we get into the Naloxone Plus specifically, I want to do just a couple slides, 2 slides on setting the stage for understanding where Naloxone Plus fits. So in the United States, there are 2 major things that have been unfolding in our field for the last few years. One of them is the opioid epidemic, right? We're aware of that, obviously. The other one, which you might or might not be aware of, is a new movement called the pre-arrest diversion movement in the United States. How many of you have heard of pre-arrest diversion? Okay, just a few hands, so good. So this will get us kind of down that road. Pre-arrest diversion is a way whereby law enforcement recognizes in people that they encounter that there are behavioral health issues, and by behavioral health I mean drug treatment, mental health, could be services, could be other things going on. There's no criminal activity involved in the majority of the cases, but the officer knows, and your officers know very well, that there's something else that needs to be done, because if I let the person go, I might see them again dead or involved in criminal activity, or if I arrest them, nothing really is going to happen because they're just going to cycle through. So pre-arrest diversion is focused on this arena of, I've got folks who've got behavioral health, drug treatment, mental health issues, and services, right? And there's no criminal activity, and I need to do something with them. If you're doing any effort like that, and you'll hear from Chief Gunther and Sheriff Tharp today on efforts that are involved in that, as part of the fight against opioids, that's called pre-arrest diversion. It goes by many other names. I won't go into that now, but whatever you call your program, that's what we're framing this out in. Okay, so in pre-arrest diversion, there's 5 different frameworks, pathways that you can take. Those are on the screen. My job's not to read the slide. I'm going to ask you to do that because I don't read slides when I present, but I want to make sure I explain it. So before we move on from this slide, make sure if you've got questions, you jot those down. So the first one is the one we're here to talk about. It's called Naloxone Plus. This is your intervention by your officers that's triggered, unfortunately, by an overdose. And your officers respond to that. Now, every hand went up when I said who carries naloxone, so you're already doing the initial response. That's saving the life once. But the Naloxone Plus framework, which again we'll go in depth on in just 2 slides, the Naloxone Plus framework, though, requires that saving the life twice, which is the connection into treatment and into recovery. That's one framework. The other 4 that you see here, the second one is active outreach. Active outreach are efforts whereby law enforcement contact people in the community who they know are in need of drug treatment. There's no charges, remember, there's no charges on board, and they say, hey, do you need drug treatment? Right? This is something new for the profession, and they do it per policy and procedure. Often a social worker or a clinician is hired through the police department to do this, or in a partnership between a police department and behavioral health agency locally, and they contact a person and say, look, there's no charges, you need drug treatment, we've got it for you if you want it. That's called active outreach. It's a prevention strategy against overdose and against future drug use, and by the relationship between drug use and crime is well known and well established, right? It's not exactly A to B, it's more like A, C, B, E, and then back to F, something like that, but it's there, and it's clear and known. The next one you see up there is self-referral. Self-referral is where your police department opens up for people in your community to come in and say, I need help, I need treatment, and they can walk into your station. Fire departments also are beginning to do this across the United States. And so that way, unlike active outreach where you are calling your department and people you hire are calling people to say, do you need treatment? Self-referrals where they walk in. People on their own walk in and say, I need treatment, and are connected to treatment. Officer prevention referrals, this is where your officers are out and about on routine patrol, answering calls, and they run into all sorts of people, many of whom they won't arrest, but again, it's that opening situation of there's no charges, there's an identified behavioral health issue, drug treatment, mental health on board, I can see that, and I know if I let the person go, in other words, don't do anything, I'm going to see him again dead or in jail. But if I arrest him, which I really don't have any charges on, but if I kind of think of a way to try to get him into treatment in jail, well, there's no treatment in jail, so it's not a good path, and I'll just cycle them through, and their situation is likely to decline. That's called officer prevention, no charges. The last one you see on there, officer intervention, is the same as officer prevention, except for there are charges on board. In other words, the chief of police and the prosecutor, they've come to agreement on a certain set of charges for which the police may act on their own, use treatment, right, use treatment instead of moving them farther into the justice system. They don't get into the jail, they don't go to court, they don't get bail bond because they're not processed into the system. That's called officer intervention. There are charges, but the police department holds them in abeyance, like an investigative status, which police do all the time, right, when they're investigating a case, or they issue a citation with mandatory treatment, but done at the police level. Don't worry too much about that one because there's not a lot of those around in the U.S. Mostly what's going on is the first four, Naloxone Plus, active outreach, self-referral, and officer prevention. So when you think about the field of pre-arrest diversion, and this is a newly emerging field, it's less than 6 years old in the United States, and that's why only a few hands went up when I said, are you doing pre-arrest diversion? It's only 6 years old, and most of the sites are 2 years old or less. So it's really, really new. You want to think about, hey, I want to go back, went to ICP, great panel presentation. We'd like to start pre-arrest diversion. This is your guide that you want to use. You can take this, and the goal here is for you to start as many of these as possible, even though you'll probably start with one pathway, and because we're talking about opioids, you're going to want to start with the Naloxone Plus pathway, but then eventually you want to build out all of them. You want people to come into your station to get access to treatment. You want to be able to reach out to them when your officers identify folks and you're able to reach them. You want your officers on patrol when they encounter them to be able to say, hey, I know you need treatment, and even if there's charges, you want to be able to deal with that. And then, of course, if they overdose, you want to be able to connect them to treatment. Again, that's the saving the life twice. What I'm going to show you next is the slide that has the more common names, what I call the brand names, that you might be familiar with. So how many of you have heard the ANGEL program? Raise your hands. Okay, about a quarter, a third. That's a self-referral model. So when I said self-referral, that's ANGEL. How many of you have heard of Arlington? Okay, 1, 2. That's an active outreach model. Chicago PD, I'm a national criminal justice consultant, but I'm headquartered in Chicago. Chicago PD does active outreach with their drug task force officers. Civil citation, anybody here from Florida? You know civil? That's pretty much where civil citation happens. That's an officer intervention. They use citation with treatment. It's not citation in lieu of arrest. It's citation with mandated treatment. Citation in lieu of arrest is just I issue a citation, you go about your way. There's an identified behavioral health need in all pre-arrest diversion. Identified behavioral health need, so it's citation with treatment. How many of you have heard of DART? And at the end of the presentation, you will all have heard of DART because that's Sheriff Tharp's program. QRT, Quick Response Team, Steer, Stop, Triage, Educate, Engage, Rehabilitate, HOPE, Heroin, Overdose, Prevention and Education, CLEAR, Community and Law Enforcement, Addiction, I think Recovery. Those are Naloxone Plus, which is what we're going to talk about here on the next slide. Those are examples of Naloxone Plus. Here's the thing about the Naloxone Plus efforts. They go by all sorts of names because they're started organically in communities by cities, villages, and counties, and they all make up their own name, which is fine. They're also hard to kind of locate and identify because they just do their own thing, which is fine that they get them started. LEAD, how many of you have heard of LEAD? Okay, a few, about a quarter or so. LEAD is primarily an officer prevention, right? Their officers, LEAD was started out of Seattle. Their officers on street while on patrol can identify folks in need of treatment and have a mechanism in policy, not informal, by which they can get those folks connected up into treatment. LEAD also handles officer intervention where there are charges also. It's not on the slide, but I want to make sure I comment on that. And then STEER, unless you're from Maryland, probably no one's heard of STEER, right? You'd have to be from Maryland. Oh, one? Okay, right. So STEER is in Maryland, like civil citations in Florida, and STEER is a pre-arrest diversion effort that can handle a lot of the different pathways, Naloxone Plus, officer prevention, and officer intervention. Okay, that was just a level setting, right? So you understand, okay, I got a little bit more about pre-arrest diversion that I know now that I did not know when I walked in here. All right, let's dive into Naloxone Plus. This next slide, we had enough handouts for about half the room. I apologize, but they are all on the app, right? The app available for you. This next slide is the one that describes the 10 elements of Naloxone Plus. Here's what I want you to do with them, because we're talking about solutions for a safer society. I want you, if you are not doing a pre-arrest diversion effort around solving, being part of the solution to opioids in the community, to take this next slide, and I'll put it up while I talk, and I want you to build your effort around this slide. These are the 10 elements based on science and research on the drug treatment public health side that we've known about for decades, and then on the police side, thanks to the work of Chief Gunther, Sheriff Tharp, and others that I get to look at as a guy who looks at this stuff nationally, have kind of pulled out of their efforts. So this is what I want you to build around. If you're already doing an effort that now you'll know is called Naloxone Plus, it's an opioid effort, I want you to look at your effort and get all these 10 elements in there if you don't have those. So do an inventory and then say, yeah, how do I get to the other elements that are in here? This is the solution piece under your leadership as law enforcement to provide your role in the opioid crisis for your community. Okay, we'll spend a little bit of time on this slide. Where I said I don't read slides, I'm going to read some of the bullet points, and that's it. So again, Naloxone Plus is triggered by an overdose, unfortunately. There's a group down in Cincinnati that I believe is going to start looking at a way to predict in advance who might be folks that need to reach out pre-overdose. So I just want you to know that, but primarily across the U.S., these are being initiated when someone overdoses. Your officers or fire EMS or some mechanism responds, and the officers arrive at the scene or at the hospital, wherever it may be. So the first step of Naloxone Plus is your officers have access to naloxone, as well as the other organizations you see up there. Every hand went up, good. You can check box that one. You have done that. The second one is you need a mechanism, a rapid mechanism by which you can identify people who have overdosed. The reason is, and this is my clinical hat on here, is that the effect of opioids on the body are very different than other drugs, the physiological effects, not the effects on the brain, right? The effects on the brain look a lot alike from drug to drug to drug. But the physiological effects of heroin are problematic, which is why you have the overdose rate that you have with it, because it slows down the respiratory system. And when we don't breathe, that gives us like a bad day, right? It kind of not a good day when we're not breathing. So rapid identification for folks who have overdosed is a critical piece of this. If you're waiting 3 days, 5 days, 10 days before you get to them, it's way too long. It has to be measured in hours and minutes. Hours and minutes. So what's a mechanism by which you can rapidly ID folks? I put up there 911. You might have other systems also. Immediate contact with the individual, how fast can you get there? Obviously, if your officers are on scene, that's immediate because they're there already, but that might require that you are doing something with another organization, fire, EMS, or even treatment already, because you want to be able to contact that person right away. And again, because of the effects of opioids. Rapid engagement. Now, rapid engagement refers to something that is going to begin to move on the Naloxone Plus model from your world as police into the treatment or the behavior health world, where you're not going to be able to do everything that's on this slide by yourself. And when I do my closing comments in just a few minutes, that's going to be what I leave with you, is that the Naloxone Plus, like all pre-arrest diversion, while you as police and first responders really have to provide a lot of leadership to get this stuff going, the solution to it, however, the overall solution does not lie in your hands or your control. You must partner with behavioral health and drug treatment, and that's new in the United States. That's new for us. We have not done a lot of this in the police world. Probation and parole in courts and prisons and jails have for decades, but for police, this is new. And this is the first step here where this probably will fall to you for a little bit, depending on how you design your pre-arrest diversion effort, but you're going to need behavioral health on board. You're going to need treatment, because rapid engagement, especially after an overdose, isn't happening, right? The person's ready to use again. They're not ready to get into treatment because they feel horrible right at that point. So it may take a few hours, it may take a few days, a few weeks, a few months. How many of you have time for your officers to stay that involved with someone along with everything else they have doing and other people are overdosing? Probably very few of you, because you have other things you have to do. So rapid engagement is a mechanism, a staff person by which you can stay in touch with the person who's overdosed, because they're not going to be ready to get into treatment at the point of overdose. Then rapid access to treatment, which means, and again, I'm giving you stuff now, shifting from the police, law enforcement world to the behavioral health world. And so it's okay if you say, boy, I don't know about any of this stuff. You're not here to do this alone, and that's why saving a life twice is much more challenging, because you have to form these partnerships with behavioral health. So rapid access to treatment means at the point at which that engagement has happened, and now the person says, I'm ready to go, they have to be able to get into treatment like right away. It's called treatment on demand. If they don't, what happens is you lose these folks, right? They say, I'm ready now, I'm ready to go. Okay, next Thursday at 8:30 a.m., you can get into treatment. They're gone, they're done. They're gonna go use again, they're gonna take off. A small number will hang on, there's no doubt about that. But they're gonna use again, they're gonna take off, they're gonna return to what we call people, places, and things that got them there in the first place. Screening and clinical assessment, I'm going to go over these last parts quickly because they're really on the behavioral health side. I just want you to be aware of them. Screening and clinical assessment is the method by which we determine who should get treatment and what kind of treatment they should get, and go from there. Tight integration, again, probably something your officers might not do because they don't have, because they don't have the time to do it, which is fine. And so the idea is you're going to have to partner with behavioral health to make sure that you have the ongoing integration with this individual on the street, in their home, and in your community. Medication-assisted treatment, all I'll say on that is there are medications in the United States now. There's 3 of them, methadone, Suboxone, and Vivitrol. Those are brand names on the last 2, and those medications are used for people who suffer from opioid use disorder. They are highly, highly effective. It is not one drug for the other. One is a medication approved by the FDA, given under controlled circumstances. The other, heroin and opioids in general, are used incorrectly. So these 3 medications being on board in what you build out. Recovery lasts a lifetime. When a person's in recovery, they'll go up and down, up and down, up and down. But the point is, if you want to stop their drug use, if you want to reduce overdose and overdose deaths and reduce crime, you've got to have a mechanism for recovery. And then finally, naloxone, you want to make sure that the person has access to naloxone and their family does. Why? Right now, we're finding, depending on what state we're in or what jurisdiction we're in, that many folks, in fact, do not call 911. And so the ability to have naloxone there in the house or in the community available will stop the life from being lost because they don't have access and they don't want to call 911. Okay, so that's the thing, the Naloxone Plus framework. Just want to show you 2 more slides. When I present, I don't go through all the slides because that kills people, it puts you to sleep. You have those. I usually just pick out a few, and I want to show you these. This one I think is the last one because I'm getting the time signal. Okay, now here's the thing. Because you have to interact with this solution for the behavioral health world, the question I'm going to ask you next is how many of you have clinical experience in drug treatment? And some of you might. Clinically certified, clinical training by background, not drug recognition and enforcement, which is totally another important aspect of this, but clinical. Okay, 1 hand goes up. The reason I present this slide is it's important for an audience that doesn't know what the research and science says about how long it takes and what it looks like when someone gets in recovery, is that you will have unrealistic expectations about what happens to someone when your officers naloxone them. You followed the Naloxone Plus framework and you call me 2 months later and say, Jack, you told me to do that, we did it, we put the program together, and 2 months later they're back on the street. That's right, because it takes a long time. If you have anybody in your family in recovery, friend or neighbor, and statistically more than a few of you do in this room, this is actually based on the science and research what the time frames look like. This is a critical element for law enforcement officers to know when you do pre-arrest diversion, so your expectations are matching the reality of what this looks like for people. Because time's short, I don't read them anyway, but I'll just put them all up at once. And what you can see in that first year, which is really a minimal amount of time, that's about what you're getting in year 1 and not much more than that. That's good. They're going to stop drug use. They're going to reduce their contact with law enforcement with you, but that's about it. And that's if they're working the program and able to stay and to get abstinent and stay abstinent. That's it. All right, this is what it looks like, folks, in reality. Okay? All right, let me leave then just a few closing comments. I said I don't go through all slides. I haven't done that for years, so you have the rest of the slides in your packet. I open up by saying that we are here because IACP is talking about solutions for a safer society. Your role then, so what does this mean for me, Jack? What it means for you is that your role in the opioid crisis post-naloxone is a critical one, and it is about partnering with behavioral health, drug treatment, and mental health in your community to build out a Naloxone Plus framework. And what Chief Gunther and Sheriff Tharp are going to present to you, you will hear that clearly. It's police plus behavioral health. It's not in your control. Behavioral health's not in your control. It's not in your knowledge base. I asked who knows it, one hand went up, but it doesn't need to be. That's the good news. This doesn't have to fall to you. You don't have to feel like you have to bear the weight of this. So what I ask you to do specifically as my final comments is go back to your community on those that don't have an effort, provide the leadership as police chiefs and as sheriffs and as superintendents and commissioners and whatever the titles that you carry. Provide the leadership. Go to your drug treatment providers and say, hey, we've got a challenge in our community. I saw this presentation on Naloxone Plus. I want to start one of these efforts. Drug treatment will respond, I promise you. They're excited to work with you. And if you're in a community that's already doing a Naloxone Plus effort, whatever you call it, I want you to take this slide, convene the folks together, and you're probably in a partnership, so you don't need to call them anymore. You all just get together regularly at your leadership level, not the line officer level. Your leadership counts, your leadership matters. Convene them, get them together, and say, we got this Naloxone Plus, let's build out the rest of the elements. Why? Because the solution is saving lives twice. Once in Naloxone, the second one on the connection to treatment and getting them into recovery. Your community's less crime, less drug use, less deaths. And that's the solution that you can be part of. Thank you.
All right, let's finish up with Jack's slides here.
Oh yeah, you gotta run through.
So what I'm going to give you is one solution to this particular problem that you just heard Jack talk about. This program is called The Way Out, and what's unique and nice about this particular program is it covers a couple of the gamuts that Jack covered. So this can be post-naloxone, this can be officer prevention, and this is clearly a voluntary referral on behalf of the substance user. And so this program was designed out of a larger group, as you heard Jack talk about, but in Lake County, which is just north of Cook County, Chicago, somewhere halfway between Milwaukee, Wisconsin, Chicago, Illinois, we have a county of about 700,000. This program actually was initiated and started via street officer conversation with chiefs, saying, we're tired of going back to 123 Main Street on every Friday and reversing that overdose. There's got to be something more we can do, Chief, to help these people so we don't have to continue to go back. And so that's the post-naloxone that you heard Jack talk about. And that's where this program really initiated from and how it came to be. This is a collaborative group effort with everybody that you can think of. And I will get to the specific partners that we utilize to put this program together. But it was launched in June of 2016, and it's a 24-hour day, 7-day-a-week program. It's available currently right now at 11 police departments out of 33 within our county. So 11 participating departments are entry points for this particular program, and also utilize it in the post-naloxone base. Again, no charges are ever filed if an individual seeks us out voluntarily, or if in the officer's discretion at the street level, he feels this would be a better application than pushing someone through the criminal justice system. And consequently, when we have an overdose and we go there, just after that overdose, when that individual comes back, this program is immediately offered, and we can push this person through the program from initiation to treatment provider in as short as 90 minutes. And I'll tell you how we do that. These are the partners that we put together. And what's important about this, let me explain to you very quickly what the program and how it works. And then I will tell you the most important part of it, and that's creating the infrastructure to support this program. So the program is very simple. It's designed that once contact is made with the substance user, either voluntarily they walk into our police department, which is about 90% of the time, believe it or not, or at a post-naloxone reversal, then the officer initiates the program by punching your normal complaint that you would normally do. We do it in a citizen assist drug assistant That's what we kind of punch on it. The officer runs the individual through a criminal history check. We're looking for some certain things, but let me just say that criminal history alone does not preclude the individual from going through this program. I'll talk about that in a little bit more length later on. Once that criminal history is done and that person's cleared that portion of it, then there's a contact to our health department. We utilize our county health department as kind of a central hub. They have a 24-hour crisis line that's staffed with crisis workers who are trained in various models, and they run the individual through a quick screener over the phone. With the officer, the participant, and the health department employee, they ask a series of questions. Those questions are designed to kind of dig into what the use is, when the last use was, are there any other underlying mental health issues that need to be considered, are there any underlying medical issues that need to be considered. That then determines what path this individual is going to take. Our program is set up with both an outpatient track and an inpatient track. One of the big learning lessons that we found out when we started this was our treatment partners told us 85% of the people that are going to go through this program will be suitable for outpatient. But what we have found is the exact opposite. We have people with their bags in hand entering our facility saying, I need inpatient. I've been through outpatient 7 times. I've been through inpatient 3 times. I can't go back to outpatient. I need inpatient. If you can get me a bed, I want to go right now. And so we do everything we can to accommodate that individual. Even if it means driving 2.5 to 3 hours to that very close bed, that's the closest one we can find. We do that, that's the commitment from law enforcement. So once we've done that and walked that person through that and determined that path, then it becomes a warm handoff between law enforcement and the treatment provider. We transport them directly to that facility, that available bed. Again, we can do it in as short as 20 to 30 minutes, depending on where the bed is located, to as long as a couple of hours in some cases. But on average, we're able to get that person from us to initiation to the bed in about 90 minutes. So now let me talk real quickly about the infrastructure, which is the important part of this whole thing. If you want to do this, these are things to think about on the front end. Creating that so you can support it. The last thing we wanted to do is create a program that someone utilized and we had to say no to them. We knew it would fail immediately because the biggest advocate of this particular program is the actual users themselves. Actually, they've gone through the program not once, but twice, but 3 times they'll come through the program because they saw that it worked. And then when they meet those individuals in treatment and they pass that word along, the next time that person comes to your law enforcement agency and they walk through that program. And that's how this begins to spread. Setting this up, you see the police departments on the left, not the most important thing. Some of the big important partners to make sure you have at the table at the beginning, your state's attorney. Some of the road bumps out east with similar programs were the DAs or the state's attorney in that particular region, saying the discretion didn't belong in law enforcement, didn't have the ability to negate a felony possession charge and not charge that individual criminally. So you want that state's attorney or your DA at the table with you, understanding the importance of this particular program. We had that from day one. 2, the probation department. How bad would it be for someone to walk into your department looking for help who's actually already on a probation and be in possession of the narcotic, and then they just revoke their probation? The probation department agreed that as long as the state's attorney was on board, they would not petition to revoke an individual if they voluntarily sought us out or if the officer was able to initiate that voluntarily with the individual at the time of overdose. The Lake County Bar Association or your Defense Attorneys Association. What better referral than defense attorneys? Many of those relationships are already created between the user and their defense attorney from prior contacts with the criminal justice system. And who better to refer them if they know that this program's real and legit? They'll tell you, go to the police department and turn yourself in. They'll get you help. And it's been done. We've seen it happen. The judges, all of the judges were on board. The chief judge bought into the program immediately. That's an important part. But the single most important entity to engage before you create one of these programs is the user population themselves, the 12-step community. If you are going to target a product to a particular group, you better find out what's going to get that group to utilize the product. We did. We sat down with the 12-step community. We asked them, what would help you come to a police department? What would help you trust in law enforcement to be the pathway to treatment? And so they even changed the name of our program. Our program was originally titled First Chance. They didn't like that because they felt that insinuated it was our only chance, our last chance, and so they wanted the change to be a way out. We did that. Because of that, you'll see the success that the program has had as I move towards the statistics. An important entity, all of our hospitals in the county, all 4 major hospital groups in our county are partners in the program. What does that get us? That really just gets us priority when we have to take them to the emergency room for a medical incident. It gets us priority to get them fast-tracked through the emergency room as quickly as possible. And then a number of treatment providers. You have to reach out, you have to get creative. If that treatment provider, like I said, is 2 hours away, but they have a variety of beds, you need to make sure you engage them and do it in a tiered system. You have your primary treatment provider, then you have a secondary and a third and a fourth and so on. Memos of understanding. One thing that I would encourage you if you create this type of a program is at the very front end of everything is make sure everybody knows exactly what it is they're getting involved in. When I say that, we're all in law enforcement. You have to, on the law enforcement end, be willing to allow your officer to drive 3 hours to drop that person off. That's the importance of the program. That takes that person, that guy or girl off the street for that long, but that's the commitment at law enforcement level. We created a memo of understanding for all of our partners so everybody knows exactly what they are participating in and what the rules of engagement are, if you will, at the beginning. The program participant waiver, these are all available again online, and the brief screening tool. If you want to know exactly those questions that are being asked at that front end, utilize this, go to it, take a look at those questions that are being asked. And the program participant waiver really is that assistance for us to avoid the HIPAA issues. And they sign off on allowing us to exchange information with both the hospitals and the treatment providers. I will tell you, that is a one-way path. It does not come back because of HIPAA. We can share it with them up that path, but we do not get any information on the back end. I'll explain how that works in just a minute. Here's some data. This is at 1 year. This is at June 1st of 2017. From June 1st of 2016 to June 1st of 2017, 183 people utilized this program in one form or another. Today, I can tell you as of last night, 256 people have utilized the program. So we're seeing our numbers increase dramatically as time goes on. In fact, the month of September, 34 people utilized the program. It's the busiest month that we've had since the program's been started. This is some real quick snapshot of data. Where they're going residential, as I told you, 151 of them have gone to residential, 11 to outpatient. You can see the breakdown of male and female. When it started, it was pretty much 50-50. We're starting to see more males now access the program. One thing I will say that we are digging into on our data is the race. The race data is not reflective of what our county is, and we're still trying to figure that out. We believe that clearly that is going to take some time in building up that trust with our minority communities, but we are seeing minority representation coming to the police departments and utilizing this program. And again, age. This isn't anything that's unique to this particular program. These are the drugs of choice in particular. This is another interesting aspect of this program. It is available to anyone for any substance use disorder. While we're talking about heroin and opiates right now, alcohol is also is the second leading, and we've helped out many of those that are struggling with alcohol addiction. Benzodiazepines, cocaine, methamphetamine, I know that's a big one in some of our southern states. So this program is available to any addiction. Anybody can come in for anything. And then you see the referring departments at the bottom. Clearly mine is the largest, but I want to just preface, in case my mayor happens to watch the recording later, of those 80, those are not necessarily my residents. In fact, I know they're not. I can tell you of that 80, 8 were actually residents of my particular community. The other 72 were from other communities. Our program does not cut out anybody from any place. I have actually, as a side story, I had a mother bring her son in from Nashville, Tennessee, which is an 8-hour drive to my police department. I had a mother bring her son in from Ohio, again, about a 6 to 8 hour drive to get assistance. We can't always help out-of-state people, but we will never leave them high and dry. So in those cases, we have been able to help those individuals. I will cut this all out because this is a lot about what Jack has talked about already. But the one thing I want to point about that particular slide is here's where I see one of the greatest benefits of programs like this, any type of pre-arrest diversion program. You are building trust with a particular portion of society that has never trusted law enforcement ever. I am seeing in waves people coming in that have been struggling with substance use for years. that come in and they want to see the officer that helped them go through to thank them, to tell them, this is the first time I've been clean more than 30 days in my entire life. And the last person I ever thought was going to give me the assistance was a cop. And so this is building trust in portions of our community where there's never been trust before. I see that, and I hope that this will translate into that trust building with our minority populations also. My particular community has a 32% Hispanic Latino population. And so I'm hoping that that will come along as time goes on. The last, you heard Jack refer to, one of the important parts of putting these programs together is that, that data, and analyzing that data and the outcomes. We partnered with Rosalind Franklin University to study this particular program. They're looking at two aspects. They're looking at, one, the most important, does this program work? How does it work with certain portions of society? Do females utilize this program more? Are they more successful than males, etc.? They're digging into that kind of data to determine whether that works. They came on about 6 to 7 months after the program started, so their first data we expect at the turn of the year. Second, they're also looking at an opinion portion. What is law enforcement's opinion before the initiation of the program of substance users, and what is their opinion after utilizing this at 1 year, at 2 years, at 3 years? Is there a change in law enforcement's opinion of those that struggle with substance use disorder? And conversely, what is the substance user's opinion of law enforcement? What is the community then's opinion of substance use disorder? Again, trying to break down that stigma, if you will, that we all know exists with this particular disease. That's our program in a nutshell. What I can tell you is, I know there's a lot more details. I'm sure there's a ton of questions. I want to leave some time for Sheriff Tharp to get into his program too. Please see me afterwards. You're going to have questions about buy-in. You're going to want to know the intricate details of how we created this and got it together. You're probably going to want to know how much it cost. Look at it right here. Zero, folks. This is how I always end it. If you want to do it, and it's the right thing to do, you'll figure out a way to do it. And it's all collaboration, it's all partnerships, it's getting the right people at the table. Everyone has an interest in this particular issue. Otherwise, your communities are dying. They're dying in massive amounts, and that's going to continue unless we do something about it. So we've used $0 to this point for this particular program. Not that we aren't looking for money to sustain it long term, believe me, I understand that. However, creating it and getting up and running for over a year now, we've used $0. Okay, thank you.
Good afternoon. I'm glad you left your slides up there because I don't have any slides. So I just wanted to have an old fireside conversation with you and tell you what we have done in our community in Toledo, Ohio. If nobody knows or ever heard of Toledo, we're about an hour from Detroit. But I wanted to, you know, I was thinking about coming out and talking with this group, and I saw a commercial on about an insurance company, and they said that they know a thing or two because they've seen a thing or two. Well, talking to law enforcement people, a law enforcement person talking to law enforcement people, you already know much what I'm going to talk about and have seen it and done it and et cetera. But I just really wanted to kind of share with you what we're doing in our community and how we started doing this. But so 46 years now, excuse me, I've been in law enforcement. And I never, ever thought 46 years ago when I was working in the narcotic squad, and our goals were just to kick doors and arrest people and kick more doors and buy drugs undercover and kick more doors. But I never thought that we would be talking about diversion and pre-arrest and deflection and all that. That's certainly foreign to me. And still, for the most part, excuse me, it is foreign to me. But what we started doing about July 2014, I became sheriff, and you know, there's no master's degrees in how to be the sheriff, or no master's degree probably of how to be the police chief, because I've never been a police chief. But I do, and what I do is that I come in at night, 2 in the morning, 1 in the morning. I ride with the road patrol a lot. I come into the jail. That's part of the sheriff's responsibility, is to running the jail. And I come in to the jail at 2 in the morning and talk with the troops about family, sports, whatever we need to talk about. But what I was noticing about 3 years ago is that every night that I would come into jail, there would be somebody that was going through detox. maybe 3, 4 people in our booking area going through detox. You know, and I thought I'd seen it all, being a combat medic in Vietnam and the years in the homicide squad. You know, you get it, you understand. But I'd never seen anybody go through detox. It was pretty nasty looking to watch young people do that. I'm curious, how many here have ever actually watched somebody go through detox? Yeah. So every group I ever talked to, and not the whole group ever raises their hands, but this one night, this young fellow that was going through detox, he was clean cut looking, 29, 30 years old. He was screaming and crying, and he was throwing up and urinated on himself, and his legs were flailing, his arms were flailing, and again, he was a sharp-looking kid. And he actually kicked one of the correction officers in the leg that was in with the nurse, and he apologized to the correction officer. Well, I had never seen an officer kicked in my entire life, and somebody turn around and apologize to him, and I thought, you know, maybe this person's not as bad as what my throne is, what my thoughts are about people that are heroin addicts and dealers and so on and so forth. So I checked with the fire department, and you might want to do the same thing. I talked to all the police chiefs or fire chiefs, and I asked them, how many overdoses are you going to? And the numbers were just amazing. But we in law enforcement 3 years ago in our community, we weren't hearing about the overdoses, because what was happening is the fire departments were going to the overdoses, but the call would come into 911 is that my daughter can't breathe, or my son fell down the steps. Well, people didn't want to say that my daughter's a junkie and she just shot up with heroin. You know, they wanted to protect her, so they would take her to the emergency room, get her treated, and off she goes and released. So we decided what we would do is all these calls that were coming in, I'd asked the fire chiefs to start calling our dispatchers and letting them know these are overdoses. And just hundreds of overdoses were coming in a week, and we couldn't believe it. So we had decided that what we would do is we would try to just put 2 officers in a unit and to see if we couldn't get them to detox. And so the only I was looking back about 45 years ago, and my partner and I, we responded to an overdose. And the only overdoses that I'd ever seen 45 years ago, and many of you know that people weren't dying the way they are today, is that people were using heroin, but they weren't overdosing and then dying. But I'd only seen 3 people that actually died in my entire career, and that was a response we went to, and there was one in the living room dead, and one in the kitchen, and one in the bathtub, half full of water. All we did as law enforcement officers is that we just got a hold of the coroner, and we made out probably a quarter of a page report as what we seen and what we did, or what we saw and what we did. And so we decided to just put 2 officers in a unit to respond to these overdoses to the hospital or to wherever they overdosed, and see what we could do with them, and see if we couldn't talk them into taking them to detox right then, right that minute. Well, the numbers were so high that 2 officers, that didn't work whatsoever. So I called the Attorney General in Ohio, Attorney General DeWine. He's still our Attorney General. And I was shocked that he called me back within a half hour, and I never thought that I would get that kind of response. You know, it's just the sheriff calling from one of our 88 counties. He called back, and I told him what we wanted to do is that we wanted to expand this unit, and we have responded to so many overdoses. And he called me back in about a half hour, and he said, you know, Sheriff, we're gonna help you out with this unit that you want to put together. And to make a long story bearable here is that shortly thereafter, he brought in $700,000 to our community, Lucas County in Ohio, and part of the money went for additional officers, additional deputies, and part of it went for beds, detox beds, because we didn't have that many beds, recovery beds. And so we expanded the unit. Our county commissioners, we talked to them. They helped us out as well. They expanded the unit, knowing that what we needed, it had to be done. So we've gone from 2 officers today. We have 24 officers in this unit, and that's all they do is they respond immediately to overdoses, and they talk people into going to detox, letting them take them to detox. The majority of this group are full-time officers, and then there's some part-time officers in the unit. But we couldn't get to 24 unless we had the help of other police departments. So we had other police departments that we reached out to help us to put officers in the unit. But not only the police departments, is that when we looked around the universities, they have 2 universities, they have a police department. So they gave us officers, and I deputized them to give them arrest powers throughout the entire county. And then we had our park rangers in our community that are certified peace officers, and they put an officer in the unit. We deputized them. It went on to actually our library, believe it or not, our Lucas County Library has law enforcement officers, but they just have arrest powers around the library, so they gave us an officer, and I deputized them as well. So we're up to 24 officers, so they're responding to these overdoses immediately and taking them immediately to detox. Well, we know that window is very narrow, and oftentimes people don't want to go to detox, but our deputies, they talk them into it. They convince them that there's a chance, there's a possibility for them to keep their lives or keep themselves alive. And they're not charged, they're not arrested for drug abuse, for shooting the heroin. So we respond to the hospitals immediately. So we ran into a situation when we first started with HIPAA. Everybody talks about HIPAA. Well, the officers started showing up, and it scared the emergency room nurses to death that we were there to investigate, and they didn't want to share the information with us. But over time, that we were able to convince them, and working with them and our attorneys, is that to respond to the hospitals on an overdose is no different than responding to the hospital on a shooting, a stabbing, a homicide. You officers, you know that you never have a problem when you're responding to a felony investigation. These are felony investigations. But what we're doing is that we're getting a handoff from the nurses to us to be able to talk to them to try to get them to detox. So the question is, why aren't they arrested? Well, our jail, I got 2 minutes left. Yeah, you guys had a lot of time. And it was good. So the bottom line is that our jail is full, and we don't have the room for them anyway. But I wanted to sum this up by talking, and Eric, you made a great point about the trust, is that I had told the officers, don't try to make informants out of the addicts when you first meet them. Build relationships. The relationships that they have built over the last 3 years, and has been over close to 2,600 overdoses that we have taken people to detox and worked with them. But the information that's coming through to our officers is amazing. It's unbelievable. Because they've built their relationships, the families are providing information, the people that they helped are providing them information. We just did a 52-count indictment in our community of major drug dealers in our community, and all this information came from the people that we assisted and helped. I just want to mention one other thing about being able to sustain that unit. So you have the 24 officers, but then also comes the cost of the cell phones, the cars, the fuel. Where do you get all that money? Well, our community has done so many fundraisers for us. It is just unbelievable how much money they have brought in and given to us and we have a 501c3 now, and to us to be able to keep that unit running, to be able to get them the equipment they need to be able to provide services. For an example, is that we have a Louisville title, the largest title company in our community. They come in and they ask me, how much longer are you going to be sheriff? I told them at least 4 years, and we're just elected. And they said, well, here's $10,000, and what we'll do is we'll give you a percentage of every closing we have for the next 4 years to be able to maintain your unit. And we've had car dealerships that have given us cars and automobiles, because a lot of these people, they don't want to jump in, and we still have some of those four-door Crown Vics, those Jack Webb looking cars. You guys are too young to know who Jack Webb is, but a couple of you in here know, and right? So anyway, we have new cars that have been given to us by dealerships, and that's how we're maintaining the unit. And so the unit is continuing to grow, and we thank you so much for letting me share that information with you.
Okay, I know there are going to be lots of questions and that we're done in 10 minutes, 5 minutes. Who can stay a little bit later and is not rushing? All right, good. If you can stay a little bit, they'll answer your questions. But we still have 5 minutes, so don't rush out. Do I have any questions from anybody? Okay, yes.
Great job, Chief. Great job. One thing that I had a question for you was with the program. We're doing similar on the East Coast. I'm from the East Coast, and you referred to last year. Have you got any blowback from public health? Because we are now saying that we're outside our warehouse where this is really, it's a great program, but it should be law enforcement pushing the cart. Are you getting that at all from public health?
No, and primarily that's because we brought them in on the front end. They're actually the quarterback of this entire program, if you will. And so they make the determination, or they make the advisement of, does the person go outpatient, does the person go inpatient, do they have mental health issues that are struggling, are there medical issues? So because they are making the call, for lack of better purposes, they love it.
Well, I'm not talking treatment, because we have that. It's on the other end, as far as some of the terminology coming up as rapid detoxification, that these programs may be having more of a negative impact by just putting people into detox. Have you started to hear that at all?
No. We've, there's going to be some critics on the treatment that's provided to them. One of the things that you saw Jack bring up in his slides, and really the reason I think that our program is particularly popular, is our treatment providers provide medically assisted treatment. And so they're literally walking into our lobby and they will tell you to the minute, you got 37 minutes before I go bad. I need to be someplace where I've got buprenorphine or something in my system. And that's where they want it, because they know that we have the medically assisted treatment. And so once that handoff is made, there's not a lot of information that comes back from the treatment provider. Unless we see the person back out on the street, that's when we know they didn't quite make it all the way through.
Anybody else? Oh, yes, back there.
So I'll speak to that. In the United States, all states have involuntary confinement for mental health, some variation of it. 37 states have, and that's in the packet, laws on the books that have some version of that for drugs and alcohol. But what I want to say is I don't know of a single state that's actually using it collectively for overdose yet. So no, and I would tell you be very, very careful with that, because everything with involuntary confinement is very complicated, and an overdose is not a mental health. So I put it in the packet so you can see laws in the books that really were designed for alcohol and DUI cases. They wrote the legislation saying, okay, we'll throw in drugs or whatever the legislation says, not anticipating where we are right now in the United States. It was done for the DUI guy who just goes on the road over and over. So no, can't say much about it, but in a year we might know more. Kentucky, last thing I'll say, the state of Kentucky, for example, does have experience with using it, using the law in the books for that. I believe Ohio might. I know that they have the pink slip that they can do it with. I just don't know what the numbers are on it. They're probably not very high. It's an extremely complex situation. I just want you to be aware of it, okay?
There's a question right there.
Yeah, if you were to approach this as an operational plan, how many MAT physicians are you engaging into? How many physicians would DEAX or medication-assisted treatment physicians are you engaging?
Repeat the question.
Law enforcement training and medical addiction medicine training.
So how many MAT certified physicians are we engaging for this particular program is the question, I believe. And so the simple answer is I really don't know, other than to tell you that our treatment providers, a number of them are certified and able to do MAT. So our primary, which is Gateway, which is a national foundation, they have doctors on staff that are allowed to do the MAT. We also use some outside physicians as referrals if those beds happen to be full at that time in order to get those individuals with MAT. So we right now are partnering with 4 main treatment providers and then some doctors that run businesses on the side that are certified to do the MAT. So I would say probably a half a dozen. Yes, how many, right, absolutely. Yes, we're aware of that, but we have not run into any problems to point with that.
And let me just one thing, as a guy who looks at this stuff nationally, yeah, MAT's got the 30 and 100 limit right now. In your community, if you find medical providers that are willing to do medication-assisted treatment, we'll say Suboxone and Vivitrol, remember that very few doctors can build a whole practice on this. So what you're probably going to have to do is approach a variety of doctors, and if you live in rural areas, you're going to go a long, long way to find the doctors who say, I'll take 2 or 3 people, or I'll do the medication, but I won't do the treatment part of it. So it's a little bit more complex than just the medication, because it must be tied into treatment. That's your best outcomes. So just kind of be aware of that in and of itself. But I'd love to have a conversation, because a big part of what we do is the behavioral health medication and treatment side of it, not just the police side. So, yeah. Absolutely, yeah. More so than the medical community, most doctors in the United States are not trained on addiction, treatment, or what that means. They see you episodic for what they have, but not on addiction or treatment. It's not part of medical school in the United States as a regular part of the training.
Anybody else? Okay.
I just have one more question about, so you get them clean and sober, and they're living this sober life. What, is there a next step, like, to employ them, to get them into society as a productive person?
I'd like to mention, one of the things that we're doing is that our DART officers, not only are they getting them into treatment, but they're doing follow-up with each and every one of those, and they continue to work with them. And we have gone to bat with private industry to get them jobs, whether it would be in restaurants as dishwashers or whatever the case may be, but we need to keep them busy and active and give them that sense of community. Otherwise, they'll be back out shooting heroin again. Right. And then the other thing I wanted to mention, doctor, is that we have 9 treatment agencies that have volunteered to come into our jail and work with people that are addicted, and they're doing that on a regular basis every day. And so we opened up a wing of our jail, just people that all of them are addicted, that our treatment agencies are coming in and working with every day.
Yeah. Before I take any more questions, I just want to mention that if you're still interested in this topic and would like to go to one more session, tomorrow at 12:30 in room, I think it's 102, there's a session called How to Build Partnerships Between Law Enforcement and Public Health Agencies to Address Opioid Use. And so that's tomorrow at, what did I say, 12:30. So, you know, just FYI. And also, if you came in late, you can still get your badge scanned in room 108, which is not on this level, it's downstairs. Any more questions? Is there anybody whose hand I can't see? Thank you so much for coming. And there are still handouts for DART. Thank you so much. And thank you guys for participating. Have a good day and enjoy the conference.
Yeah, that's good.